though there are several hormones which play a role in this glucose homeostasis, the predominant role is played by the interplay of insulin and glucagon. Now, insulin is released from beta cells of pancreas and glucagon is released from the alpha cells of pancreas. Whenever we take meal, particularly rich in carbohydrates, the glucose level in the blood increases from the metabolism of that carbohydrate. Now, this increased glucose level in the blood circulation stimulates the pancreatic beta cell to release a endogenous hormone called insulin. Insulin is a catabolic hormone, it's an anabolic hormone, sorry. Insulin helps in mainly, there are two important roles of insulin. One is it sensitizes the cells, particularly in the skeletal muscles, for uptake of glucose, where the glucose is further oxidized, which is also facilitated by insulin only in glycolysis, and which helps in releasing energy on which we all are thriving upon. And secondly, after the uptake of glucose in the cell is sufficient and still we are left with, you can say, excess glucose in the circulation, then insulin helps in storing this glucose, you can say, for at the time of need that it can be released. The storage form of glucose is a polymorphic structure called glycogen, and the process of making of glycogen is called glycogenesis, which is also facilitated by insulin. Now, this glycogen releases glucose at the time of fasting or at the time of stress, or when exogenous glucose is, for some or other reason, is not available to us. This process is facilitated by a hormone called glucagon, which is released from the alpha cells of pancreas. So whenever the food is limited, or whenever, even on day-to-day basis also, after an overnight fasting, at least when you have taken your last meal 6 to 8 hours before, then what happens, gradually the glucose level in anybody of us, even a normal individual, not only diabetic but in normal individuals also, when the glucose levels start lowering, the first response of lowering down of glucose level is reduction in insulin secretion. So when the glucose is slowly coming down in the body, when you have not taken meal for say couple of hours, and the glucose is slowly coming down in the body, and the glucose has reached its threshold value of say 80 to 85 milligram per dl, at that threshold value, the first response is reduction in the insulin secretion from the pancreatic beta cell. Just after that, if the glucose level reduces further down, then what happens? The glucagon hormone is released from the pancreatic alpha cell. This I am telling you just also normal physiology and also the defense mechanism which is set in the body, the homeostatic defense mechanism set in the body against hypoglycemia. So at threshold of 80 to 85 milligram per dl, the insulin secretion is coming down. At a threshold of say 65 to 70 milligram per dl, the glucagon is going up from pancreatic alpha cell. Now this glucagon helps in glycogenolysis at the level of liver and releases glucose from glycogen which is stored there. And also this glucagon facilitates gluconeogenesis from amino acids, from glycerol, from pyruvate, which is a byproduct of glycolysis and all. This gluconeogenesis takes place mainly at the level of liver and also partly at the level of kidney. So both this process, that is glycogenolysis and gluconeogenesis, are part of defense mechanism of body against falling glucose levels, that is hypoglycemia. Now, are these two hormones, that is insulin and glucagon, are they the only hormones which interplay between this hyper and hypoglycemia? No, they are not the only hormone. There are role for other hormones also, but as I said, insulin and glucagon are predominant hormones. Apart from insulin and glucagon, other hormones play their role, like growth hormone, cortisol, and epinephrine. So similarly, at a glucose threshold, which is slightly less than 65 milligram per dl, after glucagon secretion is at its full form, or glucagon secretion is at full level, Still, if suppose for some reason the glucose does not goes up, in normal physiology, glucose is supposed to go up. But in event of an hypoglycemia for some or other reason, which we will be discussing in our next slides in detail, why hypoglycemia can happen. In that circumstance, maybe even after full-blown secretion of glucagon, still suppose the hypoglycemia is not reversed, then other hormones play or come into picture. These hormones are epinephrine, which are released at a threshold of 65 to 70 milligram per dl, growth hormone, and cortisol, which are also released at a threshold of 60 to 65 milligram per dl. So just to have a recapitulation, in event of an hypoglycemia, the first response of body is to reduce insulin secretion from the baseline to almost zero level. Second response is increase in glucagon secretion. Third response is increase in epinephrine secretion. Fourth response is increase in cortisol and growth hormone secretion. Now a spontaneous question which you can ask me, that why to remember such sequence of responses? All these responses are there, so how does it matter what is the sequence? No, it is very important to remember the sequence of this response, because the responses are interdependent on each other. What I mean to say is, if one particular response does not happen, the subsequent step is not activated, and this is something which is miraculous in our human body. For example, if the insulin secretion, endogenous I am saying, if the endogenous insulin secretion is not reduced, then the glucagon will not rise, and so the epinephrine will also not rise. Now, what is the significance of this piece of knowledge? The importance of this piece of knowledge is we have both type 2 and type 1 diabetes. This is one reason why type 1 diabetic people and people who are late into the course of diabetes, late into the natural history of type 2 diabetes are more prone to recurrent hypoglycemia. Why? Simply because people who are having type 1 diabetes have almost no endogenous insulin secretion. Similarly, the people who are having type 2 diabetes for a long time, say 10, 20 years, late into course of natural history of type 2 diabetes, their beta cells also get exhausted and they have almost nil endogenous insulin secretion. And therefore, in event of an hypoglycemia, the first step, that is reduction in insulin secretion, probably does not happen properly, and therefore the subsequent steps are also defective, that is rise in glucagon, rise in epinephrine. This is one reason why type 1 diabetic people are subjected to recurrent episodes of hypoglycemia. Now, the neuroglycopenic symptoms which we see with hypoglycemia are because of increase in the epinephrine secretion. For ease of convenience, the hypoglycemia has been divided or classified by the American Diabetes Association into 3 levels, you can say. The level 1 hypoglycemia is basically hypoglycemia alert value, which is defined as a hypoglycemia or the glucose level, random glucose level of less than 70 milligram per dl. Level 2 hypoglycemia is when the glucose level is less than 54 milligram per dl. And level 3 hypoglycemia is any hypoglycemia which you can call severe hypoglycemia. The definition of severe hypoglycemia is any hypoglycemia which requires third-party assistance for correction of hypoglycemia. So if your patient gives you a history of, Doctor, I had an episode of hypoglycemia in which the documented sugar was 60 milligram per dl, but I was unconscious. My wife helped me by putting some sugar drops or sugar juices in my mouth, and then I gained my consciousness. Then that patient did not had level 1 hypoglycemia, but that patient actually had level 3 hypoglycemia or severe hypoglycemia because he required third-party assistance to get back to normal level. Now, this difference between level 1 and level 2 hypoglycemia is that is cognitive symptoms. The cognitive symptoms are only seen when the glucose level drops to less than 54 milligram per dl. The predisposing factors for hypoglycemia can be many, but you can conveniently divide it into 4 or 5 subtypes. For example, insulin or insulin secretagogue administration, which is excessive, ill-timed, or of wrong type, that is the dosing are wrong, is one of the most important causes of hypoglycemia. Apart from when the exogenous glucose delivery is limited, for example, if a patient misses meal or after an overnight fasting. Similarly, third important category is glucose utilization is when the glucose utilization is increased, for example, after a heavy exercise by a patient. These are the factors which can make a patient prone to hypoglycemia. Similarly, when the endogenous glucose production is less, for example, after alcohol ingestion or after fasting. Similarly, when the sensitivity to insulin is increased, for example, few patients will typically come to you with a history of intense lifestyle modification resulting in weight loss, and now they are encountering frequent hypoglycemias, which they did not encounter previously. So this is because of improved insulin sensitivity, and therefore they will require dose reduction. Similarly, when the insulin clearance is decreased, for example, in chronic kidney disease, in chronic liver disease, then they also become prone to hypoglycemia. Apart from this, advanced age and hypoglycemic unawareness are also important causes of recurrent hypoglycemia. Hypoglycemic unawareness is a phenomenon which I will try to discuss in my subsequent slide. Is the big topic actually. The symptoms of hypoglycemia are, it can be autonomic or neuroglycopenic. Autonomic symptoms are trembling, palpitation, sweating, anxiety, hunger, nausea, tingling. And neuroglycopenic symptoms are difficulty in concentration, confusion, weakness, drowsiness, vision changes, headache, dizziness. So neuroglycopenic symptoms of hypoglycemia are evident with level 2 or when hypoglycemia is less than 54 milligram per DL. So hypoglycemic symptoms based on blood glucose level, this I have already mentioned. The neuroglycopenic symptoms will come at level 2 hypoglycemia, and autonomic symptoms will come. They can come even earlier. They can come when the glucose is just below the level 1 or the hypoglycemic alert values also. So why is hypoglycemia detrimental? Hypoglycemia can even be fatal. That should be the beginning point. Apart from being fatal, fatality from hypoglycemia is actually not very common, but then hypoglycemia can lead to irreversible neurocognitive damage if not corrected properly, because you know that brain has supply of glucose only for 5-7 minutes, and therefore if you cut off the supply of glucose from brain for more than 5-7 minutes, then irreversible damage can happen. Hypoglycemia is harbinger of mortality also. In ICU setup, patients who are encountering recurrent hypoglycemia are more likely to die from their native complications also, not just from hypoglycemia, but from the disease with which they are admitted in ICU. Maybe because hypoglycemia increases the thrombotic risk, it increases inflammation, and it also puts patient at increased risk of cardiac arrhythmias. Arrhythmic deaths have been reported due to hypoglycemia in large randomized trials also, like NICE sugar trial. In the origin trial also, it was seen that most of the death which happens because of hypoglycemia are actually because of the arrhythmias which are precipitated by hypoglycemia. There are several responsible mechanistic explanations for arrhythmia due to hypoglycemia, but mainly it is because of the increased sympatoadrenal response, which is actually a defense mechanism of hypoglycemia, which might, in a susceptible individual, promote the patient for producing more ventricular premature beats and QT prolongations, which can lead to hypoglycemia-induced arrhythmias. Now, hypoglycemia and cognitive impairment. Hypoglycemia can cause cognitive impairment, both short-term and permanent. Recurrent episodes of hypoglycemia in an individual has been seen to be associated with increased risk of dementia and cognitive impairment. So hypoglycemia, if severe, even single episode can cause cognitive impairment. Even if not severe, recurrent episodes of hypoglycemia have been seen to cause cognitive impairment, which is in similar lines as vascular dementia or Alzheimer's disease per se. Treatment of hypoglycemia. So before going to treatment of hypoglycemia, and this is not part of slide, but I like to just briefly discuss 2-3 points on important term related to hypoglycemia called hypoglycemic unawareness. Also a related term is called HAF, that is HAAF, which is called hypoglycemia associated autonomic failure. You must be you must get yourself aware about these terms. This is because as I already mentioned, late into course of type 2 diabetes or in type 1 diabetes, when the endogenous insulin secretion is almost nil, then in event of hypoglycemia, particularly when there is an episode of severe hypoglycemia or an episode of say hectic exercise by the patient, following that, so following an episode of severe hypoglycemia or following an episode of hectic exercise, particularly when the patient is not used to doing that, what happens is patient's sympathoadrenal response to subsequent episode of hypoglycemia is deranged or derailed, because one point is endogenous insulin secretion is not happening. Second point is because of absence of that, the glucagon is not releasing, and also the sympathoadrenal response, that is increase in epinephrine release, is also not happening. So what happens is, because of absence of the sympathoadrenal response from the adrenal medulla, the patient does not have the neuroglycopenic and sympathoadrenal manifestations like palpitation, tremor, which usually happens with hypoglycemia. And therefore, the patient might be having severe hypoglycemia but not symptomatic at all. Many of times you have been seeing this in your clinical practice also, particularly for hospitalized patient or otherwise also, that patient will complain you that he saw, for some reason he saw his blood glucose and it came around 40 milligram per DL, but at that time he was not having any symptom. So these are the patients who are having autonomic neuropathy and having hypoglycemia associated autonomic failure. You must take this patient very seriously because they are at increased risk of cardiac arrhythmia and subsequent sudden cardiac deaths, and you must loosen their control for a couple of months. This loosening of control of couple of months should be actively monitored, and it has got some criteria also. So you can take help of your endocrine colleagues also, that how much loosening you will do for this patient, so that you can take him out of this hypoglycemia associated autonomic failure. If managed properly, this is a reversible situation, but then you need to manage the patient meticulously for this. Now coming to treatment of hypoglycemia, we all know fast-acting carbohydrates, 15 to 30 grams of fast-acting carbohydrates are used. You should use direct glucose if the patient is on glucosidase inhibitors like acarbose and voglibose. Otherwise, you can use glucose or polymorph forms of glucose also, like dextrose and all. And after giving glucose, you need to check the blood glucose of patient after 1 hour whether he has recovered or not. You will repeat that 15 to 30 grams of glucose if he has not recovered. And subsequent to recovery, you will ask the patient to take a meal containing complex carbohydrate so that he or she does not feels or does not encounter secondary episodes of hypoglycemia. Glucagon has got all its place in management of hypoglycemia. 1 milligram glucagon can be given subcutaneously stat, but then this is something which is less used in India. Again, that glucagon has got some limitations because it is difficult to use glucagon in type 1 patients. So coming to the hypoglycemia prevention part, as I already mentioned, the risk factors for hypoglycemia, needless to repeat. You need to ask patient to monitor his blood glucose regularly using SMBG and take care